And I mentioned here the issue of breast radiation toxicity, because we deal with a very special population. If you treat a patient with 80 years old and you have to deal with toxicity that's going to occur in 15 or 20 years, who cares? If you deal with a population, like I see every day, of 30, 40 years old, and those patients are exposed to radiation and may survive, and we hope they survive, and after surviving, they will develop a complication, that's unbearable. And so I think that this presentation, if anything, applies very much to the Middle East. So on this last presentation, and I'm not going to go through extensive description of constraint and DVH and things like that, not at the end of the day. And also the presentation from Dr. Al-Omran really was very thorough on that, and I would advise you to go back to her presentation. But I would like to talk about skin toxicity, cardiac toxicity, very well known, lung toxicity, a bit less known, but very applied to the Middle East, lymphedema, we talked briefly about it, and other toxicity that we read in the literature. What about skin toxicity? Well, used to be frequent. We have acute side effects, and here's two graphs that I took from the breast IMRT randomized study, multi-center in Canada. You have here the occurrence of edema. Here you have the occurrence of erythema. The yellow line is the occurrence of desquamation, moist desquamation, which is painful, and that's why the pain follow that. And this is what the doctors see. You have the beginning of the radiation. First week, there's a bit of edema, no other thing. Second week, you have something peaking, and the doctor don't see. But what experience the patients, not what the doctors see, because the patient can have a toxicity at the end of the treatment or 2 weeks later. You see that all the patients in the breast IMRT receive 5 weeks of radiation, but the toxicity could occur up to 10 weeks after. And so the cumulative incidence is way higher. So it's always important when you talk about toxicity, especially the acute toxicity, to see what the doctors see, the differential toxicity and the cumulative. So you have redness, and that's very, very frequent. You see that erythema is close to 100% of the patient will experience that. Dryness or itchiness, which is an plaque and sweat gland that make micro cracks in the skin, and the patient tend to scratch and to itch, that due to the dryness. Edema, the problem is that could be due to surgery, could be due to radiation. It's not very specific, but a lot of patients experience edema. You see that 50% of the patients experience edema. Moist desquamation is due to radiation. Don't blame the surgeon, don't blame the chemo. Actually, chemo seems to protect. It is due to radiation, and that generates a lot of pain, and that's really unbearable for the patient. Hyperpigmentation comes later due to melanocyte, and that will eventually fade. Acute, and now we have the permanent and delayed side effect on the breast. So if we do breast conserving surgery followed by radiation instead of mastectomy, it is a cosmetic reason, correct? We don't want to have a mastectomy. So the permanent and delayed side effect should be avoided at all costs. Otherwise, why did you do radiation in the first place? Most of this radiation, and I took that from a seminal paper published in 1987, has to do with the impact on microcirculation. Something which is very specific to the skin is that 5 millimeters below the skin, 3 millimeters exactly, you have a network of microscopic vessels, and they're communicating. But then within the 3 millimeter, you have the skin functional unit with a single microvessel. If you impact on it, then you will have a skin necrosis. So you will have permanent side effect if you impact on endothelial cell, so the cell from the blood vessel. And then that will generate hypoxia, healing, and telangiectasia. When new vessels tend to grow, you will have this awful and ugly redding area in the skin, which is cosmetically detrimental. You can have an impact on the basal cell and the glandular cell, and that will create some skin atrophy and dryness, which is, of course, compounded by the impact on microvessel. And then you can also have an impact on fibroblasts, and then you will generate some fibrosis and induration. Some patient that you can see treated a long time ago can have very hard and chest wall, almost like a shield. So something which is important is that there's a compounding of permanent side effect if there's pre-existing condition like age, possibly diabetes for sure. A patient that has diabetes has way more high risk to develop some permanent side effect, and smoking seems also to be a factor because it impacts on the endothelial cell and on the microcirculation. Important also to say there's been a couple of studies, and our study also, showing that in radiobiology, we always say you have the acute or the delay, but there's no correlation. Not true for breast. Lila study in 2007 published that there's definitely a correlation. Patients who experience moist desquamation will develop telangiectasia. And we also show that. I'm going to show that to you later on the breast IMRT study. So what are the risks of moist desquamation, which is the most difficult side effect, acute side effect lived by patient? So if we look at post-mastectomy with or without bolus, the risk of extensive, like very aggressive grade 3 moist desquamation, when you don't use a bolus, never. If you use a bolus alternate day, 1 patient out of 5. If you use it daily, you double the amount. So using daily bolus is not a good idea. After whole breast radiotherapy, you treat a way larger volume. There's a lot of more heterogeneity into the dose distribution that you have in the breast. And we see that there's been a series of studies that show that after standard radiation, moist desquamation should be 38 or 20%. Our breast IMRT study claimed, no, it's close to 50%. And I recall there was some debate when we presented this study at Astro, some people saying, no, I never see any moist desquamation. It's not true, less than 10% of the patient. And I said, when did you assess the patient? Oh, during radiation. Yes. But the peak of moist desquamation occurred 2 weeks after the radiation. Because if in our study we look what was the rate of moist desquamation before the end of radiation, it was only 26%, but you double it when you finish. So radiation oncologists always say, I don't have moist desquamation. And the medical oncologists who see your patient 2 weeks after say, you burn all my patient, because moist desquamation occur after. So we have to prevent it. So prevention trial. There's been a lot of trial, and I'm going to cite here only a couple, about what can we do, either any topical we could use to prevent moist desquamation. So William published in 1996, aloe vera, negative, doesn't improve. Fissure, not another fissure. There's a lot of fissure. An RTOG study testing biafine, because biafine for many years was sold as a skin protecting ointment for radiation. Negative study, didn't show any improvement with or without. There was a study from Canada, Roy, as a single center randomized clinical trial using skin washing. It was a negative study. But if you dig well into the study, it might be a question of power. You don't have a lot of patients, about 150, if I recall well. He still had fewer grade 2 and fewer moist desquamation, like half of moist desquamation, if the skin is clean. So although he concluded it's a negative study because it was not statistically significant, the odds show a trend that you could probably reduce by half. So I think keeping washing your skin during radiation and keep it clean is always a good idea. The only positive study is a study from Sweden, Bostrom. He used steroid cream and he showed a highly significant reduction of erythema. Unknown if it's an impact on skin toxicity or if it's just because of vasoconstricting effect of the steroid, but definitely reduce edema. So if you have a big erythema and even sometimes some itchiness, I think it's a good idea to prescribe some steroid creams. Now, what else can we do? And I think there was a very interesting study from Royal Marsden. Fernando in 1996 follow up 197 patients and say, what are the factors of risk of moist desquamation? And he found that the most important factor of risk of moist desquamation, so radiation technique was comparing lateral decubitus versus supine. So we don't do lateral decubitus anymore. Beam energy, seems that lower beam energy increases skin toxicity. Yes, more hotspot. But the field separation and the dose heterogeneity. You see the most important factor, the existence of dose heterogeneity into your dose distribution will create tenfold more moist desquamation. And where the moist desquamation increase is where you have the hotspot, inframammary fold, and the axilla. So that means that improving the dose distribution, we may be able to improve the toxicity. So you see here a dose distribution. You see that if you just use 2 open beam with wedge, you're going to give a very high dose in the inframammary fold, protect the center of the breast where probably there's a tumor, and increase the dose to the axilla where it's very painful under the arm. So this is where 1996, William Beaumont proposed to use breast IMRT, and meaning it's a technique where you use field in field, use a 3D improvement of the dose distribution. The aim is not conformality. The aim of the IMRT is dose distribution homogeneity. So how do you do a breast IMRT? Well, first, you're going to generate a plan, a 2D plan like we used to do, and without any compensator. And then you're going to have a hot spot on the close to the nipple, and then you have all your 5% isodose. So if you generate a sagittal plan, you have a hot spot on the top and cold spot here, you can segment your isodose. So the idea will be to deliver the dose by open beam, and as soon as you reach the 100% on a hot spot, you're going to put a segment and a segment and a segment and a segment. Basically, you're going to alter your 2D wedge with a 3D complex wedge to alter and to make sure that all the breasts receive 10%. So you have to create the 5% monetary limit segment. And what we did on top of that when I was in Canada is not only to do forward IMRT, but to do an inverse IMRT. What you could do when you develop your plan and you have your segment, you use several points inside the breast and run an optimization where you're going to alter the weight of the segment in order to improve the dose distribution, not only the sagittal plane, but across the breast. And inverse breast IMRT for dose optimization of dose homogeneity is way better, we publish on that, than just a forward plan. And that's what we use into the breast IMRT study. So here's an example of a breast IMRT. I have my patient, and I will deliver about 80% of the dose with open beam. And as soon as my open beam has reached 100%, I'm going to use segment to ensure that I give the remaining of the dose where it needs to be. The first result from a dosimetric standpoint were amazing. You know, if you use wedge technique versus breast IMRT on 2D plan, you see no difference. But when you look at a sagittal plan, you can realize that if you had a hot spot of 15% on the inflammatory fold, which was typical, you can totally reduce this inflammatory fold. So the real question is, okay, I know that a hot spot will generate more moist desquamation. But it doesn't mean that reducing my hot spot, I will have less moist desquamation, because it could be because of the rubbing of the breast, because of the frailty of the skin. I need a clinical trial. And that's what we did in 2004. We submitted for a grant to randomize to do a multi-center randomized trial where any patient referred to have radiation to the breast only were randomized between 50 grain 25 fraction using standard wedge, 2D compensation versus breast IMRT. The first thing we learned, this was the 350 patient required for the study. And we assume the study will take about 3 years. And most of the time when you do a study, you hope that, and you're a bit under the curve because accrual is difficult. What we discover is patients love the study. If you go to a patient and you say to your patient, you know what, I'm going to give you a new technique that maybe you will have less skin burn, they all sign for it. So our obsession sometimes about cure, cancer, things like that, sometimes we don't realize that what the patient wants is a better quality of life, a non-painful treatment, mafi halam, like I say, and something that will improve their quality of life. So we had 238 patients accrued, and it's a positive study. What we showed in this study that we reduce by almost by 30% the risk of moist desquamation, and especially in the inflammatory fold. We follow that by a follow-up study. We call back all our patients at 8 years. And we say, okay, we reduce the acute skin toxicity, but do we reduce the long-term side effects? So that was a little bit challenging because, you know, it's long time after, and we don't know if the two are correlated. And we choose as an endpoint to say, well, you know, a lot of patients complain of breast pain, like 48% complain of breast pain. So maybe we can reduce the breast pain. Unfortunately, it's a negative study. But very interestingly, on the multivariate analysis, we learned that young age and occurrence of pain during radiation are associated with patients that will have chronic pain, have a miserable quality of life. The occurrence of moist desquamation during radiotherapy is significantly associated with telangiectasia and fibrosis. So we confirm Lila discovery that acute side effects are correlated with long-term side effects. And we also find that patients that estimate they have a very bad cosmetic outcome is also associated with pain. So the self-confidence, the self-appreciation of the cosmetic is associated with the pain, and pain is associated with the fact that you have acute pain during radiation. So here's a little bit of the learning we have from the two studies. Acute side effect. When you have a moist desquamation, this is significantly associated with high pain and low quality of life. Now, moist desquamation is not associated with chronic pain, but acute pain is super highly, meaning when a patient had a pain, they recall and will have pain for the rest of their life. So there's no direct correlation, probably because of power, but moist desquamation creates acute pain that creates chronic pain. When you have an acute pain, you have a chronic pain, and in both cases, it's go with a lower quality of life. And when you have a moist desquamation, it's significantly associated with telangiectasia and fibrosis. So fighting against moist desquamation, fighting against acute pain, which is reduced by IMRT, can potentially reduce all those long-term side effects. Who benefits the most? That's the second question we ask, because we had patients that have small breast, medium breast, and large breast. And for small breast, we have an incredible reduction of moist desquamation from 14 to 3%. Medium breast, only a third. And large breast side, whatever you do, even IMRT, you have hotspot heterogeneity and you have no reduction. So those patients need something else. And this is when we came and we replicate the study, and instead of IMRT, we use supine IMRT versus prone IMRT. And that was based on data from Ghent, actually. It's a Flemish study, a single center out of 100 patients. They show a threefold decrease of moist desquamation when you use prone technique. So we decide to do that, but to select the D plus patient. And we run the multi-center Kenyan prone study, published by my friend Danny Vespreni. Out of 378 patients, kept D plus, we randomize them prone versus supine. And because of a change of dose fractionation, people were moving from 1525 to moderate hypofractionation. Half of the patients were treated with extended fractionation and half fractionation. And this study is a positive study published in JAMA Oncology. It showed that prone reduced the moist desquamation from 39% down to 26%, so another third. And also on multivariates, supine is worse than prone, like twice more. Extended fractionation also is worse. So definitively, if you treat your patient with moderate hypofractionation and prone, you may have a better result for things. And of course, a boost was a negative thing. This was for the skin. What about cardiac toxicity? Well, nothing that you don't know. There's this fantastic publication by Darby that look at the correlation between the mean heart dose and the risk of major cardiac event. And this is really due because, for many patients, we want to irradiate the internal mammary chain. And when we want to cover it, the anterior part of the heart tend to be in the field. And that's exactly where you have the interventricular area. And based on a very complex analysis, they use retrospective data out of 2,168 women treated from 58 to 2001. Based on 2D dose distribution, without CT planning, they estimate, depending on the dose, the technique, and the body mass index of the patient, they estimate, based on phantom, the average mean heart dose. And so they plotted that with the outcome, knowing exactly how much cardiac event happened to the patient. And they came with this very, very well-known curve showing that every time you increase by a gray, you have 7.4 relative increased risk of cardiac event. What does that mean? That means that if you have a 3 gray mean heart dose at 50 years old, you will create an additional 0.9% coronary event and 0.5% of mortality absolute risk. Doesn't seem a lot, doesn't seem dramatic. But the thing is, this is really worse if you have pre-existing cardiac condition. So if you're a smoker, if you have diabetes, if you have BMI, that's very bad. But what I would like also to show you is something which is called the Agatston score. That's a research that was done in the Netherlands by the team in Utrecht. I was part of this study. They evaluated the patient with what you call coronary artery calcification. You see, when you do a CT scan for a patient, you do your CT sim, and you find that sometimes you have a huge amount of calcification on the interventricular area. And there's a way to quantify this calcification. And the Agatston score is over 400%. There's an absolute 15% risk of major cardiac event, most of the time leading to death within 10 years. It is independent. How important it is. Just imagine a patient that has three other major risk factors. Like, for example, a patient has diabetes, he has a large BMI, and he's a smoker. It's not 15%, it will be 2.5%. So you have six-fold time more risk than really three major factors to develop a major cardiac event at 15 years if you have an Agatston score. So that's an easy thing to catch when you do a treatment planning for a patient. You look, you see the IVA, you say, oh, I really need for this patient to reduce the mean heart dose, or maybe I don't even need radiation because the risk of dying is way too high. So I think that's a very good trick. So what are the timing of complication for cardiac disease? This is also part of the Darby publication. You see that from 0 to 4 years and 5 to 9 years, the increase of major coronary events was not 7.4%, but 16% and 15% in the first 10 years. In other words, most of the cardiac complication has been captured in randomized clinical trial because most of the randomized clinical trial follow up the patient 10 years or more, and because the cardiac event occur very soon. So, is there another way to protect for cardiac event? We saw that from the presentation earlier by Rim Alomran that you can use a deep inspiration breath hold. But what about techniques? It's impossible to realize a clinical trial where you're going to randomize a patient between various techniques and see which one gives the more cardiac event. It's not ethical. And I mean, you have to follow patients too long. It's not a huge event rate. You may need too many patients. But what you can do, because you have the Darby publication, you can compare technique on the same phantom, measure the dose, correlate the dose to the risk of major cardiac event. And that's what we did in Canada. And you can see here that when you treat a patient, 50 gray in 25 fraction, medium breast sizes, the mean heart dose will be 3 gray. So we will have what we expect, like less than 1% risk of major cardiac event. If the patient are large breast, you have 6.39 gray. So that's double. And that's probably not acceptable. Meaning that this patient with large breast may not be ideally treated with whole breast radiotherapy. Either you reduce the dose or you use a different technique or you use a prone technique. The prone technique completely reduces the dose of the heart. If you use whatever technique of partial breast radiation, the dose is always below 3 gray. So APBI is an excellent way, accelerated partial breast radiation is an excellent way to reduce the dose to the heart, and it's probably not associated with a significant increase in cardiac toxicity. Now, there are some patients that sometime, not eligible for PBI. Here's a patient that's post-mastectomy, not eligible for PBI, not eligible for deep inspiration breath hold, because this is a patient that I saw in the Netherlands. And you see the difference in green and pink between deep inspiration breath hold and free breathing. The heart and the shape of the anatomy is such that whatever I do, I will give a very huge heart dose. And this patient actually is probably eligible, and like Rim said, for proton, because this patient for which I want to treat the IMC, with proton, I can probably completely shield the heart. And the way we were doing in the Netherlands is to use a model-based approach. And the model-based approach, it's you take a CT scan and you do a plan optimization for photon, a plan optimization for proton. You're going to take each of the voxel and you're going to multiply the voxel by the normal tissue complication probability, the NTCP. And then you're going to compare the dose that the heart, for example, is receiving with protonon versus photonon, proton and photon. And if you see that you have an improvement of more than 2% of complication, if you have more than 2 to 5%, depending of the kind of complication, the grade of complication, then you can say it's worth to you to treat this patient with proton. And surprisingly enough, we found that a good justification of proton would be treating the IMC for young women, because in those patients, the risk of the cardiac is a risk of mortality, is a very high risk. And you can dramatically reduce the mean heart dose using proton. And proton for challenging anatomy and patient on which you want to treat the regional lymph node because you have a survival benefit can be a very good indication for proton. Now, what about lung and secondary lung cancer? That's something that we talk, in the wine, but not very well explored. So 2022, Overgaard published the 30 years of the post-mastectomy trial. And what she showed that there's an absolute difference. You see in red, the post-mastectomy radiotherapy and no PMRT, the risk of secondary primary lung cancer was double. You double the risk of secondary lung cancer when you have PMRT. And not only that, but you also increase the risk of mortality. So you have an increase of mortality. The problem is that it's not significant. As you can see, the odds ratio across the value 1 all the time. And probably the problem is a problem of power, because after the 3,000 patients, only a few number, like a sixth of the number, really reach the 30 years old. There's another publication done by the team of Sarah Darby and Corinne Taylor, again building a very complex model based on the rate that they found of secondary cancer in the population, and they multiply this risk by also other factors like the smoking. They find that the patient who have a 5-gram mean lung dose, if they are non-smoker, there's a tiny increase, but if they are smoker, you have a huge increase. So they conclude that depending on the other risk factor, you may consider to really reduce the mean lung dose. And this difference was much more important for risk of cancer death, lung cancer death, than for heart disease death. So we entertained the same goal. We decided to calculate the risk of secondary cancer for patients based on dosimetric data, because today we can calculate very accurately the dose in the lung, the mean lung dose for all our patients, depending on the technique. And we use also the Beer model, which is something which is available online, a very complex model that for low dose in any organ can calculate the risk of secondary cancer. We evaluated the dose both in dosimetry, using, for example, standard breast irradiation in a phantom. We calculate the dose, but also we measure the dose. We measure the dose using GAF chromic film and again OSLD, so measurement. And we tested the dose, mean lung dose, using whole breast radiotherapy, using HGR brachytherapy, using CyberKnife, APBI, all sort of technique. And the data that we published in 2018 show that here you have the risk of secondary cancer. So here is for 100,000 patients. So it's 1%, 2%, 3%, 4%. We estimated the risk of secondary lung cancer with whole breast irradiation is close to 4%. So close to the data that Darby was calculated. And that lung cancer is the number one risk. You see that breast cancer, colon cancer, esophagus, thyroid remain very, very low. And when we compare other technique, we find that some other technique did better, but those techniques were not optimized. And later on, we decided to optimize by putting some constraint on the lung and trying to reduce the lung dose and find that APBI do way better. Why was that never reported and why people never jump on the risk of secondary cancer? When one of the things is, if cardiac toxicity occur within 10 years, the risk of secondary lung cancer, 1%, 2%, 3%, occur after 30 years. So if in all those studies, you accrue a patient of 60 years old or 70 years old, 30 years down the road is 100 years old, you don't have anybody. So it's very difficult to detect, and you need to have a good follow-up for your patient. But in the Middle East, where a lot of patients are younger, 30 years down the road, they should be alive. So that's probably more important for the Middle East. Just let's give you an example. I took some SEER data, about 80,000 DCIS from the SEER data treated from 1988 to 2012. And I compared the patients that were treated with surgery alone versus surgery and radiation. And this is very reliable in the SEERs. And you can see that at 10 years old, you have no difference. If you go to 15 or 25 years old, you're going to get exactly what was predicted in the other model, that at 25 years, the risk with radiotherapy is 8% of lung cancer and 4.3% without radiation. So you have an excess of 3.9% of lung cancer that lead to a 3% excess mortality, which is very similar to the absolute number found in the EBCTCG. So we pursue the modeling to see if we know the amount of mean lung dose we have for various technique, how much can we reduce the risk of lung cancer? And we use a very complex model using real statistics from the SEERs, the stage distribution, the usage of radiation in the US. We found that with standard whole breast irradiation, in the US, radiation will probably generate 3,625 lung cancer. And 80% of those patients will die, so 2,009%, 900 excess death. If we use VMAT whole breast irradiation, we may reduce by 9.9% because VMAT you can put a block on the lung and reduce the mean lung dose. If you use fast forward 26/5, you reduce by 40% the risk of lung cancer. If you use a prone technique really gives a very low dose to the lung. Well, 70% reduction. And if you use 3D CRT APBI, only 43%. But if you use 26/5 APBI, 60%. Just imagine a shorter 3D CRT PBI in prone technique. You're probably going to wipe up all your thing. Multi-catheter reduced by 71%. The seeds, 80%. And when you use 4-pi, a sort of non-coplanar, so it was a CyberKnife robotic irradiation, you reduce by 85% the risk of lung cancer. Techniques count, and that's probably very important for the Middle East. I think in the Middle East, if you have a DCIS that is diagnosed in a young woman that is likely to live longer and she needs radiation, I would consider APBI, or I would consider something that really reduces the mean lung dose. Quickly, two other complications. So lymphedema. Lymphedema is, we talk about it, but I want to come back to the data of the AMAROS trial. AMAROS, again, was shown to show that after one node positive on a sentinel node, survival is equivalent if you do full axillary dissection versus radiation. But the benefit of not doing full axillary dissection and radiation is you reduce the risk of lymphedema. You can see that across the board, if you do axillary lymph node dissection, you have a lot of lymphedema, and those lymphedema is half with radiotherapy. There's a beautiful paper from Korea where they followed 772 patients that has axillary dissection, and retrospectively they see they receive or not radiotherapy and lymphedema. And they found that the risk factor for lymphedema is a large number of node removed, which is the case in the Middle East, regional radiotherapy, and adjuvant chemotherapy. And you can see that the rate they came was close to 38%. That's a very high risk of lymphedema. And food for thought. When I was trained in radiation oncology, and they're still practicing like that, I heard at Princess Margaret Hospital, we used, the classic three-field technique, meaning that, we estimate that when you have a full axillary dissection, there's no point of delivering radiation to the level 2. Level 1 will be in the field, but level 2, there is no need. It has been removed, and we just want to cover the node that the surgeon cannot remove. And in our center, actually, at Sultan Qaboos, we have decided that for a patient where there has been a fair amount of lymph node removed, we just treat the top of the level 2 and the level 3 nodes. There's probably no need to deliver radiation at this level. Other complication, to come quickly to the thing that you have heard, asymptomatic lung pneumonitis, when there's field going to when there's some radiation going through the lung. On CT scanner, 1 patient out of 4, you will find some change. Most of the time, it's asymptomatic, and 20 grade the threshold. Very rarely, less than 1%, you can have an extensive pneumonitis, and you will see the pneumonitis extending, fibrosis extending beyond the field. This patient needs steroid. It's rare, but it can happen. So you have to follow up your patient and think about steroid in this case. Esophagitis used to be very rare, but since we are contouring now the superclav and adding all the margin, we tend to touch on the esophagus. So esophagus grade 1 is frequent, and less grade 2 is a little bit less common. But when patients have that, I think it's a good idea to do some mouthwash. Listerine is better than the magic mouthwash. At least had a better taste. And also sucralfate work very well for most of the patient. Hypothyroidism is rare. 6% of the neck is in the field. But now that we control the thyroid, we can minimize that. But that's something we have to follow up. And the last thing is rib fracture. I've treated over 6,000 patients in my life, and I follow them carefully. I never seen a rib fracture. It's a very rare event, and I think even rarer than what they cite, 0.125%. But it seemed to be more frequent when you re-radiate a patient, and people have cited a number of 19%.